Hi there, it's Luisa Lyons here, midwife at IBCLC, and the other job I also have is that I'm a tongue tie practitioner. So I trained as a tongue tie specialist midwife back in 2017. I've done around 2,200 divisions and assessed around another 1,000 babies where I haven't performed a division but given feeding support. So I have got a lot of experience with tongue tie, otherwise known, as I prefer to call it, as restrictive lingual frenulum because it's more anatomically correct. RLF or tongue tie refers to when the lingual frenulum, so the frenulum under the tongue, I haven't particularly got one, but if you look in the mirror at yourself, when you put the tongue to the roof of your mouth with your mouth wide open, the lingual frenulum in some people, about 1 in 3 people, is visible. And tongue tie, or RLF as I prefer to call it, occurs when the lingual frenulum is too short or too tight or both. And the effect of a lingual frenulum that's too short or too tight or both is that it restricts normal tongue function. It's important to say that some babies have a short or tight lingual frenulum and restricted tongue function, but can breastfeed perfectly well and have absolutely no symptoms, and the mothers have no symptoms. However, with a particularly short or tight frenulum, those cases are more unusual, but they do still happen, and I still see people where their baby has quite an obvious short, tight frenulum, and yet they are asymptomatic. So just the presence of a tongue tie visually doesn't mean that you'll have problems, and that's one of the reasons where the debates around should we check all babies at birth comes in, because essentially what are we checking for? What we don't want to do is check for the visual appearance of normal anatomy. So the lingual frenulum is visible in 1 in 3 people. That doesn't mean that 1 in 3 people need a frenulotomy, which is the procedure to cut the frenulum. What we do need to be aware of is when there are problems with feeding that are related to that short, tight frenulum. So what we should be checking for at birth is feeding problems rather than a physical visual appearance of a frenulum. And we do that. We check with the breastfeeding assessment tool and the bottle feeding assessment tool, depending on how you're feeding, or if you're mixed feeding, with both of those tools. And if any issues are flagged on that as being not normal in terms of the length of feeds, the frequency of feeds, urine output, stool output, jaundice, behaviour at the breast, any soreness of the nipples, any blocked ducts, any engorgement that's not resolving, then we need to look at why. And one of the areas that we rule out is the oral anatomy, so that we make sure that the reason for any of those issues is not to do with the lingual frenulum being too short or too tight. In terms of what percentage it affects, it's hard to say. That it's an area that needs so much more research. The available evidence that is often quoted in the NICE guidance suggests that about 11% of all babies will have a shorter or tighter than average lingual frenulum, and about half of those, so about 5.5%, would benefit from frenulotomy. However, this research is quite old and it has been disputed more recently, where many people working in the field of restrictive lingual frenulum feel that true incidence may be higher. So part of my role as a research midwife 2 days a week is to try and get funding and try and get interest into more research into infant feeding and issues like restrictive lingual frenulum. In terms of the management of it, we always aim for a non-surgical approach if we can, by optimising breastfeeding, optimising positioning attachment, and if you're bottle feeding, optimising bottles, so looking at different bottles and teats. And sometimes a baby with a tight RLF that's bottle feeding can get away without any surgical division at all, simply by changing the bottles and teats, which is brilliant. And we treat based on symptoms. So if there's no symptoms of a feeding issue, then there's no need to do a surgical procedure on a baby. However, it is a minor surgical procedure with very few risks and a very low incidence of those risks occurring. So if there are problems, we shouldn't hold back from offering it to parents. And we have a really good service at my local hospital where parents are generally seen within 1 to 2 weeks. However, 1 to 2 weeks can feel like forever if it's your baby. So that's why we have private practitioners also available who usually can see you within a matter of days. So the symptoms that to look out for are painful nipples if you're breastfeeding, vasospasm, so a whitening of the nipples, nipple damage, mastitis, engorgement, blebs, so blocked nipple pores like white spots on the end of your nipple that are excruciatingly painful. If you're bottle feeding, clicking on the teat, sometimes also clicking on the breast, a sound like that. So losing suction, coming on and off the breast or the bottle, dribbling from the breast or the bottle, excessive air intake, and with that resulting excessively windy. Very, very frequent feeds, over 14 in 24 hours persistently. Short feeds, so less than 5 minutes, or long feeds, more than 35 minutes, again persistently, not just the one-off. Also, you can find that babies lose excessive amounts of weight or struggle to gain weight normally at a rate of at least 25 to 30 grams per day. You can also find prolonged jaundice or excessive jaundice needing treatment, such as phototherapy. So if any of these symptoms are ringing alarm bells for you, please see them as red flags and please seek out specialist skilled support from someone who's very experienced in assessing, diagnosing and preferably treating restrictive lingual frenulum. I have to say I was assessing and diagnosing for many years before I trained to be an actual practitioner in frenulotomy, and I look back now that I have done over 2,000 divisions, and I know so much more now than I knew then before I did divisions about functional assessment. It's not a clear-cut, excuse the pun, linear relationship. So you can have very mild symptoms of feeding issues with a very significant tight frenulum or short frenulum, and you can have very severe symptoms with a mildly restricted frenulum. So the two don't neatly correlate. So I treat based on symptoms rather than what I see. And the other thing to say is the frenulotomy procedure itself is a very low risk procedure. The main risk is of excessive bleeding, and the risk of that is around 1 in 1,000. The risk of a baby needing to go to theatre because a wound won't stop bleeding, for the wound to be stitched or cauterized, is quoted to be around 1 in 77,000. So very low risk of needing to go to theatre to control bleeding. But there's always a risk, so that's why we try to employ a non-surgical solution if possible. There's also a risk of wound infection, although I personally have never seen one, and at the hospital I work at we've done well over 15,000 divisions over the years as a team, and we've never had a case of wound infection, so it is extremely rare, particularly in breast milk and breastfed babies. The other thing to say is that the other risk is damage to the floor of the mouth, so cutting through the salivary glands, blood vessels and nerves, if the baby has unusual anatomy or if the baby moves suddenly during the procedure. So again, it's very, very rare indeed, but it is something to bear in mind. As with every surgical procedure, be that a caesarean section or a tooth extraction, there's always a risk inherent in putting sharp objects in the body, and so it's really important that you're fully aware of the risks, the benefits and the alternatives. Often releasing tight fascia around the head, neck and jaw to help sucking issues can really help before and after. There's a real lack of evidence again around osteopathy or craniosacral therapy, but many anecdotal reports of success, so do look into this for yourself. That's a really short whistle-stop tour of restrictive lingual frenulum or tongue tie with feeding, a subject that I could go on about all day, but I'll leave it there. If you would like more information, please do get in touch with me.